So I set out to make a quote quick video on VQ mismatch. Ended up being about 33 minutes, and I figured I would just maybe append a TLDR here. If anything, just kind of to ease the access, but also just to give you a quick reference if you felt like you were getting some of the VQ mismatch stuff, but just not all of it. The most significant thing here is that we have a normal VQ ratio, more ventilation at the top of our lungs and more perfusion at the bottom, because that's how gravity works. That's the fluid settling and the air going to the top. That's a normal VQ ratio. If we have VQ mismatch, it means that either our ventilation or our perfusion is out of whack. In a low ventilation uh, perfusion mismatch, it means we have a trouble ventilating, or we're having trouble ventilating, and that might be conditions like asthma, COPD, pneumonia, and pulmonary edema, all causing issues with our ventilation process, getting all the way down into here. In an extreme sense, we would refer to this as shunting, because what we're referring to is the fact that blood is starting to shunt away from these hypoxic, ineffective alveoli, right? Much like our skin in an allergic reaction or anaphylaxis might our blood might shunt away from our skin to preserve our organs. And then in any case, all of these conditions can become severe and life threatening. And that's where we'll refer to it as shunting, meaning shunting the blood away from our useless low ventilation because we're having severe mismatch. And then on the other side, we've got a high ventilation, low perfusion mustache, which I spelled incorrectly but thought was funny, mismatch here. And minor things like, though dehydration isn't explicitly or specifically a perfusion issue immediately, it can lead to hypovolemia. I'm just trying to express that that's a minor case here of low perfusion. And then in its most extreme sense, we have decompensated shock, or perhaps pulmonary embolism, which is prohibiting all movement. And so, much like we have shunting on an extreme case of low VQ mismatch, we refer to this as dead space in a high ventilation, low perfusion, much like we would in our physiological dead space, where we're having ventilation in our trachea and bronchi, but no perfusion there because they just don't have vasculature and nothing's going across the alveolar walls. So, TLDR in a nutshell, this is what shunting and dead space is referring to, and it's talking about why our VQ mismatch ends up killing us. Later in the video, I talk primarily about how if we have a shunting experience, seen here in our lower one, we have an unaffected alveolus, 70% of the oxygen, deoxygenated blood is coming through. Let me make sure I say this right. All the blood is coming through, but 70% of it is saturated with oxygen, whereas our effective one might be around 95 to 100. And when we give oxygen to people, it's not simply taking our 82% average and making it 100% in all cases. If we have shunting happening, it's taking our 95% and turning it into 100, because adding oxygenated blood to this that cannot perfuse, or rather cannot diffuse across our alveolar wall due to the shunting, it's just completely ineffective. So we're not adding 100 to 82 so much as adding 100 to the 95 in the only alveolus that are working. And so that's why oxygen is supportive but not ultimately corrective in many cases. I hope you watch the rest of the video, enjoy, and learn something in there about VQ mustache. Let's talk about VQ mismatch, just kind of what it is, what we're looking for, and why it matters. This will help kind of shore up some of the deficits I think we had from a previous lecture in regards to the airway. Firstly, as a review of our airway, of course, our inhaled air is going to come down here through the trachea, divert into our bronchi, go into our bronchioles, and then ultimately terminate at just a bunch of alveoli. And that's, of course, important to note, simply because we have air moving through this space that is ventilation, but not respiration, right? And in fact, it only becomes respiration once we get into the alveoli. And so we refer to this whole bit here as dead space. Better to type dead space, simply because we've got air moving through it, but it's not exchanging the gas across a alveolar wall. And in referencing our alveoli, I think it's super important to note that we have two primary systems at play here, right? We've got our respiratory tract here with our bronchioles, and we also have our pulmonary circulation. And so the reason I make this distinction is because, I guess, for two reasons. Firstly, we often draw alveoli like this, and I think that this can kind of imply that perhaps there's just a little bit of circulation around each one, when of course there's a metric chocolate ton of vasculature wrapping around them. But also, it comes into play, I think, when we reference things like pulmonary embolisms. I think a lot of people, when they think pulmonary embolism, think that we're getting an occlusion of our respiratory tract, when really it's an occlusion of our circulation, and that's what's happening. And that will be super important for our whole discussion here. So, like I said, we've got dead space where ventilation is occurring, um, but not respiration. And that's what we would call physiological dead space, because essentially it's a normal process, an anatomical dead space, essentially, just completely normal processes. In general, that's around 150 milliliters for adults. And moving into a discussion now about what VQ ratio is, um, we should probably just simply start by defining these things. So we've got ventilation represented as V, and this is our airflow, right? And we also have perfusion represented by a Q, which is our blood flow, right? And so, pretty simply, the perfusion is the blood flowing past our alveoli, right? Coming in as oxygenated blood, or sorry, deoxygenated blood, and then picking up oxygen from inside the alveolus and then carrying that on its way. That's normal processing. Of course, here's our perfusion, the blood flow, and here's our ventilation, both the air coming in and the air coming out. Now, what's important to know is that we always have a certain VQ ratio. Let me grab our lungs here again. If I've got lungs like this, in a sense, they're a bit like a container that if I poured fluid into, obviously gravity would take the fluid perhaps down here, right? Filling this whole area in with fluid, and it would leave the remainder of this as air, right? And so if we kind of broke this down into zones, let's call it zone 1, 2, and 3, we could see that in some instances we would have much higher ventilation occurring than we would perfusion. So with all of the air up here and very little of the fluid, we would essentially call this a high ventilation, right? And then down here, we would call this low ventilation. And so as we talk about high VQ and low VQ, what we're referring to is ratios where we've got higher ventilation than we do the perfusion, or lower ventilation than we do the perfusion. And so these high VQ, low VQ statements are in reference to the ventilation primarily. So in combination, the same principle applies largely in our lungs. Oops. Or if I were to just simply bring this over here, it's obviously much harder to see now. But the idea is the same, where we've got, zones where there's higher ventilation and zones where there's lower ventilation. And that's a pretty normal process, because essentially all of this works together to create our VQ ratio, which is a normal and physiological process. Why we're having this discussion is because we want to start talking about when these things are shifting to their extremes, and we're starting to get what we call mismatch, which is, to say that we are having a pathological experience where we're starting to have abnormally high ventilation or abnormally low ventilation ratios because our perfusion is up. And so perhaps one of the simplest examples of that might just be asthma. Um, in asthma, we're going to have bronchoconstriction, right? And so that will decrease our interior lumen, right? We're getting substantially less airflow both in and out than we were before, right? So in this case, we would say, all right, well, with bronchoconstriction, I'm not getting anywhere near the kind of air in and out that I was before. We're going to call that a VQ mismatch, because essentially my ventilation is low, even though my perfusion is completely normal. And so these things, like probably everything in life, really kind of follow just a spectrum, I guess. And if we had something like our VQ ratio here, and ration in case you get hungry for VQ, if we had a VQ ratio here, we might say, okay, well, we can have shifts of this, pathological shifts in one direction or the other. And if I've got a decreasing ventilation perfusion ratio, like I just talked about here, we might say that that's asthma, right? But of course, we can have high ventilation, normal ventilatory processes with low perfusion, right? And so maybe in an instance where we've got air moving in and out just fine, we've got no ventilation problems, but perhaps down here we've got some kind of issue, whether it be a complete occlusion, or perhaps if we're just looking at our blood volume, let's say that this is normal blood volume, it's just filling the thing up completely. Maybe we're quart low, maybe we're bleeding or not drinking enough, and so instead of having a vessel that's completely full of fluid, we've only got part of what we need. And so in this kind of hypothetical instance, now suddenly 50% of the blood is coming by that is needed. And so now I've got a perfusion issue that isn't a ventilation issue. So we would call that a high VQ, because of course we have a fine ventilation rate with poor perfusion. And maybe this is all better kind of represented like this. If you're having trouble with the ventilation and perfusion high and low terminology, let's just, I guess for sake of argument, say that our normal ventilation perfusion ratio, it's not 50%. It's actually, I think, 0.8. But in any event, let's just, for sake of argument, say that this is a representation of our normal ventilation and perfusion. And if you said, well, okay, we've got bad perfusion, right? So we're, I don't know, getting much less perfusion than we should. You can see this line shift where now we're having, a much higher representation of ventilation, right? More ventilation, high VQ mismatch, right? And so the reverse would also be true. If, like in the example of asthma, we said, okay, our line is actually shifting the other way, because as I'm experiencing bronchoconstriction, I'm now getting substantially less ventilation. Essentially, now, as you can see, we've got a low ventilation to perfusion ratio, right? We've got low ventilation to perfusion ratio. And so that's where that terminology comes into play. And so as much as asthma would perhaps be on this side where it's low ventilation, right? In this case, because of ventilatory or bronchoconstriction, we can have a high ventilation process over here where our ventilation is just fine, but our perfusion is suffering. And, maybe that's just simply dehydration, or perhaps compensatory or compensating shock, to a certain extent. And so essentially, these are what we're talking about, similar concepts, or the concepts we're trying to refer to when we talk about VQ mismatch. But of course, asthma is deadly. And so, even though we could put all kinds of things over here, we're probably looking at trying to describe the the not perspective, the spectrum of what's happening, because we could also put other conditions like COPD and perhaps pneumonia or pulmonary edema. But all of these are kind of coming with the asterisks of, just essentially saying that they can get worse and be far, far more problematic, moving us away from just calling it a VQ mismatch into something far more deadly. I mean, imagine a world where you've got just a little bit of pulmonary edema there. Maybe you had some minor aspiration, or maybe it's the very beginnings of congestive heart failure. But let's say, of course, that just continues to get worse, like in a drowning event, or just a profound ARDS experience, or just CHF that is exacerbated so much that you are just full of fluid. Well, of course, that's going to shift us farther away, and almost somewhat inappropriate, albeit true, to say, well, this very heavy pulmonary edema experience, let's call it severe pulmonary edema, that's VQ mismatch. That's true, but it's actually referred to in an entirely new description called shunting. I guess we can kind of think of it like um, that if it gets bad enough, it gets its own name. It's, in a certain sense, that's how we refer to shock. We'd say, well, you're in compensated shock. But once it becomes hypotension, we are definitively in a decompensated shock state. We start naming it like septic shock and differentiating allergic reaction to anaphylactic shock. So again, your VQ mismatch can get so bad as to get its own name. And in this case, when we have low VQ or low ventilation, we're going to call that shunting. Now, I think it's probably a little easier to talk about it on the other side, simply because we've already heard the term dead space. And so, as much as dehydration might be trending us towards a higher VQ mismatch, where we've got a lot of ventilation but no perfusion because we're dehydrated, we can also, let's just talk about something like decompensated shock. We're really low on pressure, volume, or fluid, or whatever the case is. Of course, this is high VQ over here, right? So when I say high VQ, just to remember, I like to write mustache. There we are. High VQ mustache. Essentially, it's important, I think, to associate the high VQ, because it's always referring to the ventilation when we say that. We have lots of ventilation, but poor perfusion in this case. And over here, we've got low ventilation with perfusion that is just fine, or at least for now. Obviously, on a long enough timeline, that's going to suffer as well. So again, let's just quickly, as we talk about, this getting so bad as to get its own name, and in this case, we're talking about Deadspace. Oh boy, Deadspace. We're talking about Deadspace because it's gotten so bad, whereas over here we were referring to it as shunting. Now you might say, but isn't Deadspace normal? And it is normal to have anatomical and physiological dead space like this over here. Where it becomes abnormal, and what we're referring to when we say pathological, is when we mean that it's now starting to negatively affect our alveoli, right? Because again, if you remember, as much as we're pulling air in and out of our trachea, through our carina, into our bronchi, and down into our bronchioles, none of this is exchanging across the alveolar wall. And all of that is referred to as dead space. The pathological dead space is when it not only isn't exchanging across the walls here, now it's not exchanging across the alveolar walls in our in our alveoli, right? Because ordinarily we're supposed to be having this experience where gas is exchanging across the wall into the blood, and so this is not dead space ordinarily, right? But if something is happening where ventilation is occurring and not exchanging in the alveoli, that is going to be pathological dead space. Essentially, our alveoli are useless in that case. Because if you think about it, in the case of, shock, right? We if we were just to reference hemorrhagic shock and say, well, I don't have any fluid, but my ventilation is fine. Well, now I've got, this is effectively just a bronchi or a trachea because it's full of air, but I've got no blood. And that's what we refer to as dead space. So, put pretty simply, um, we just want to be able to kind of consider these conditions that would lend themselves towards it. And as much as, all of these conditions can really trend towards a far severer case, going merely from just, VQ mismatch into shunting, which again, is a reminder, is saying that we're low ventilation, even though our blood is fine. That can be a profound problem. And dehydration, decompensated shock, these are common occurrences for this. But another also very common thing, in fact, if you were to say, hey, what's the number one cause you can think of for causing high VQ mismatch? I would in fact refer to a pulmonary embolism. And this goes back to what I was saying earlier about why I think it's important to make the distinction about how our the anatomy and physiology of our alveoli, whoopsie, because a pulmonary embolism is not occurring in our respiratory tract, blocking our airway. That would be low ventilation, right? Pulmonary embolism is a clot that's moving through our arterioles, and as it gets down into these very small portions, it's occluding the vessel and preventing all blood from going in, right? So what happens there is, of course, I've got all these alveoli all over the place. Basically, I think we kind of understand the concept of shunting in general. If you think about the fact that there is already physiological shunting that we know about, one of the most obvious examples I can think about is just the shunting of your vasculature when you are in shock, right? We start, it's part of the reason why sub-Q epinephrine is less effective than, say, intramuscular, because our body is shunting blood away from our skin to help our primary sources, right? It's like when a pregnant woman starts to get in hypovolemic shock, they will shunt away from the skin and also the baby, because, of course, you got to save the ship if you want to save the passengers, right? But even in a certain sense, if you remember back to OB, we have physiological shunting occurring in utero, where a baby's heart is literally shunting blood away from its entire respiratory tract because it's just not using it. And so it wants to maximize its energy efficiency by circulating. So there's, as much as there's physiological dead space, there's also physiological shunting. And in fact, if we were to take, a singular alveolus that was, maybe it was just this guy right here that was, collapsed or filling with fluid, that would be unnecessary energy and blood flow running it past a singular alveolus that isn't working. And so we'd be happy to know that our vasculature is going to constrict and then shunt blood away to the other effective alveoluses. And that's awesome and that's good. Of course, the problem is that if this one isn't working, this one isn't working, and in fact, all of these are not working, the shunting starts to become extreme and starts to become a major, major problem. And that's really what we're talking about when we're talking about dead space versus shunting and all of these different things. Now, what's interesting, and one of the main interesting things, if you just said, why do I, as a clinician, need to understand shunting? Why do I need to understand differentiation from, dead space? Don't I just give oxygen to people who are having difficulty breathing, no matter what these causes are? Yes, is the short answer, but it's more about trying to help you conceptualize the fact that oxygen isn't the solution. It's supportive, it's not corrective. So I'm not saying, well, don't give oxygen. Of course, it can be helpful, but I just mean to say that their problem isn't deoxygenation in many cases. Explicitly, it's some other problem. That's, if you think about it, that's like saying, a guy got shot through his arm, so I put direct pressure in a tourniquet. Boom, problem solves. He's fixed, right? Well, no, he needs a surgeon. We've got a far bigger problem. And so oxygen, again, will support these patients, but it doesn't fix their problems, where other instances, other interventions might be more helpful in the case, right? And so let's take an example here about shunting, right, and pulmonary edema. If you remember, And if you have looking balls, you can see that when we're talking about pulmonary edema, and usually pulmonary edema is going to be more on the severe case with shunting, there's a lot to be said about what's happening in a shunting experience because pulmonary edema, of course, being fluid in the alveoli, and in a severe case that's starting to fill it up, this is going to create a lot of interesting and bad problems. Now, specifically, if we were to refer to the fluid that's filling up our alveolus, or all, in a severe case, all of our alveoli, or many of them, this is causing a pretty profound oxygenation issue because oxygen is having trouble diffusing down in there. And so you might say, oh, okay, well, then that's why we give oxygen, right? Is to kind of help this experience. But because of the pulmonary edema, I mean, our oxygen essentially is not diffusing in there at all, right? It's moving around. And so, in a deoxygenated environment, our vasculature is going to start saying, by nature of the hypoxia, is going to start saying, wait, this alveolus sucks. Let's go ahead and reroute our blood from this alveolus to a different alveolus. That's the shunting experience, right? And, that's good and that's fine so long as this alveolus isn't full of fluid. But of course, if it is, now we've got another issue where the body is saying, okay, no, 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 that's actually not working out at all either. Let's shunt to another one, right? And so we start having this catastrophic shunting experience where none of it is working. And of course, as a reminder, even though our alveolus is drawn like this, simply because I can't, well, maybe I can. Let's see if I can, not quite the experience I was looking for. Our alveolus, because of the pulmonary edema in there, the proteins that are flooding in from cardiogenic shock or whatever the case is, CHF, it's also not only restricting the flow of oxygen, it's also washing out the surfactant. And so my alveolus that are usually nice and round like this being kept open due to the surface reduction of surfactant are now, kind of collapsing essentially because they have no surfactant. So even if, they're full of, some of them are full of fluid and we're helping clear the fluid, we're also experiencing surfactant washout. I mean, it is a catastrophic issue. And so early on in our career, perhaps we're like, oh, this guy's pulse oximetry is not very high. I should just go ahead and give him oxygen. And that was true then. It's still true now. But by understanding alveolar collapse and by understanding this shunting effect, it starts to come into the obvious nature of why we have to do things other than oxygen, and sooner the better if capable, right? Now, if you're ahead of me, obviously one of the things we want to do is create some pressure here. Forgive me if you hear my dog out there. He's upset about being locked out of the room. We want this to expand, to be open and held open through CPAP and the like. We need this fluid as paramedics. We need this fluid to be taken out due to diuresis. So there's a whole host of things that we need to do to solve this problem. And that's not even to say the fact that it's not correcting the origination of issues that might be a profound drowning experience or, again, the CHF. And so again, in summary, this is like, look, this is why oxygen is just a band-aid and why we have to prioritize these other interventions so bad. There's even more to be said about this, which is, I think, fascinating. Let's see what's the best way. In a case like this where I have oxygen flowing, okay? Let's say that I have, in general, I've got oxygen flowing through here. Most of the oxygen in a physiological sense that's returning to my pulmonary circulation is about 70%, right? So that means essentially as the oxygen leaves my alveoli after my blood has picked up the oxygen here, it's around 95, right? 95 to 100%. We're familiar with that. It'll go throughout my body, circulating and picking, dropping off all the oxygen, picking up all the carbon dioxide, and then returning. And it comes back as about 70% O2, right? So essentially what's happening here at our pulmonary capillaries is we're picking up 25 to 30% oxygen, right? And that makes sense. And so sometimes if our oxygen value is low, I mean, it makes sense to add oxygen to this, because if we're having problems, it's going to pick up that oxygen and move around just fine. The issue that we have is that if I think what sometimes people think is we are looking at a pulse oximetry and we're like, oh no, his pulse oximetry is 70%. I need to give oxygen. And if his cause is pulmonary edema, it's our hope to increase that. But the problem is we're not explicitly. I guess what I mean to say is the pulse ox is the mean. It's the average of all of his alveoli, right? And so if this one that isn't full of fluid is exiting at 95, obviously his pulse oximetry is 70, so something is happening that isn't this healthy alveolus, right? Just trying to draw a check mark because you're good and we're happy with this guy. If I've got one that is full of fluid, or 50% of them are full of fluid, uh, and shunting is occurring, well, we still, oops, let me close my Discord there so you don't think you're getting messages. If we're experiencing this shunting effect, well, we still have, give or take, 70% oxygen returning to our alveolus. But because it's saying, wait a second, I went all the way through this and came up with still 70%, it's just going to start shunting away from this, right? Essentially, it's not going to pick up any oxygen at all. And this, I don't know, I'm calling it 70% here, is the average of these two things, you know? And so basically, as that blood mixes, we are having an experience of, I guess this probably wouldn't be 70% so much, like, I don't know, 80, 82%, right? Let's say, to back up, we say, oh no, our person has an 82% SpO2. Really, what we're talking about there is the cumulative average, or the average of all of his oxygenation effects. So yeah, this one isn't full of fluid, and so in this specific case, we get 95% averaged with the 70% that is shunting. Now, don't get too lost or intimidated by the math. Of course, you don't need to do this. I just want you to understand it conceptually about why oxygen is less effective than we perhaps think originally. Because what did I say down here? We've got a shunting experience, right? We've got blood that is flowing through that is not picking up oxygen, right? Now we've got blood over here that is picking up some oxygen and perhaps not all. If we add 100% oxygen in either case, right, we're going to turn this 95 into 100 at best. What's this one getting turned into? Nothing. It stays 70 because, of course, our oxygenation issue is not allowing it to diffuse in here appropriately. So this one doesn't get affected at all. And so even though 95 over 70 is creating our 82, and you would think, well, shouldn't I just give oxygen and turn that 82 into 100? The oxygen that you're applying to is the 95, not the 70. And so suddenly our average only shifts by a little bit here. And we've got now 100 over 70. Oops. That would be 170 plus, or 170 divided by 2 rather. Our 82 average is only going up to 85% now. So again, I just mean to highlight and say, look, oxygen is important, but if our issue is a shunting experience where the oxygenation isn't going to occur in the places we need it to anyways, then we're only talking about going up from 95 to 100, and that's being referenced and ratioed essentially across this, which is only going to have some effect. So again, we're not withholding oxygen here, but this is the significance and the value of the other treatments to fix this thing. And much the same, I think, then we can draw a similar conclusion to say that perhaps uh, similarly, if the if it's not a ventilation problem, if it's a perfusion issue because I have a big old clot right here, well, in a similar sense, the ventilation that's coming down and the concentration of oxygen there is not the problem, right? It's the issue, or again, we have an issue of oxygen flowing through in the places that are working, but not in the places that aren't, and working through this different thing. And so we're this whole discussion about VQ mismatch and perfusion ratios is primarily just to get you to consider that we're using band-aid effects and supportive care and stabilization, and that we need to move on to more advanced treatments to affect these things. So, in summary, and perhaps most importantly, we're talking about a VQ ratio. We're talking about how if our ventilation is low, that describes us having a ventilation perfusion mismatch, with the fault being on the ventilation. Bronchoconstriction and asthma, perhaps mucus and some inflammatory issues here. Also, atelectasis or alveolar collapse in some cases. With pneumonia, we might even have a perhaps more severe issue where we're getting pus and filling up here, and literal cellular destruction. So we're starting to have all kinds of shifts, pulmonary edema. And in any case, all of these things that are causing a ventilation problem and a ventilation mismatch can get so severe as to start experiencing the shunting effect, where blood is literally just diverting around these useless alveolar sacs because there's no ventilation occurring in there. On the other side, we've got a high ventilation. Our ventilation mustache mat is just fine. And so we've got perfusion problems that on its most severe side is called dead space, because much like our trachea that is not diffusing gas across the wall, when we start to have a pulmonary embolism, here where the gas cannot exchange across the alveolar wall because there's no blood or no appropriate diffusion ratios there, now we're going to refer to that as dead space.